Hi, guys, and welcome to Psych for Everyone. Today, we're going to talk about borderline personality disorder, which is one of the most misunderstood diagnoses in psychiatry. It is often reduced to stereotypes like manipulative, dramatic, or difficult. But clinically, borderline personality disorder represents a complex developmental condition involving identity, emotion regulation, and attachment. In this video, I'm going to walk you through four things. First, how borderline personality disorder is diagnosed. The second, the major theories explaining borderline personality disorder and how borderline personality disorder develops. The third one, how to approach and communicate with patients who have borderline personality disorder. And finally, we're going to talk about some evidence-based treatments that actually work, and that's very important. So, in diagnosing borderline personality disorder, it is very important to know that we diagnose that clinically. There's no test, of course. It is based on patterns of inner experience and behavior that are pervasive, inflexible, and lead to significant distress or impairment. And that's actually very important here. The patient should have distress or impairment, or this is not a psychiatric disorder. So, according to DSM 5TR, the diagnosis requires a persistent pattern beginning by early adulthood across context with at least five of the following core domains. The first one is actually fear of abandonment, intense effort to avoid real or imagined separation. The second one, unstable and intense relationships characterized by idealization and devaluation. The third one, which is identity disturbance, and that should be a marked and stable self image or sense of self. Fourth, impulsivity in potentially self damaging areas, such as like spending money, sex, substances, or even just like reckless behavior. Fifth, recurrent suicidal behavior or self injury. The sixth one, affective instability with rapid mood shift. And this mood shifts actually are triggered by interpersonal stress. That's the main trigger for them. The seventh point, chronic feeling of emptiness. And that will lead to the eighth point, which is inappropriate or intense anger or difficulty controlling anger. We'll talk about why they lead to each other. In ninth, transient stress related paranoia or disassociation. So, really, we have two clinical points that are very critical. The first one, this is not about occasional emotional reactivity. It is about a trait level pattern. It is more than just having emotional reactivity problem. The second point here, symptoms intensify under attachment stress. Patients often function better in very structured or emotionally neutral environments. And that's actually one of the core treatment that we try to use for this illness. So, borderline personality disorder does not have a single cause. And modern psychiatry views it as the result of biological vulnerability interacting with early relational experiences. Psychodynamic and object relations models, of course, emphasize early failures in integrating self and other representations. So, from this perspective, the individual never fully develops stable whole object representations. And that's the very important point here. So, people are experienced as all good or all bad. depending on the emotional state of the moment. This explains splitting, idealization, devaluation, and relational chaos. Margaret Mahler's separation individuation theory places the problem in early toddlerhood, particularly during the rapprochement phase. The child struggles between autonomy and dependency. And when caregivers are inconsistent, intrusive, or emotionally unavailable, the child fails to consolidate object constancy, leading later to abandonment anxiety and unstable identity. And this is very important in borderline personality disorder. Now, attachment theory reframes this as insecure or disorganized attachment. So, caregivers are simultaneously needed and feared. As adults, patients seek closeness for regulation but experience intimacy as threatening, leading to push pull dynamics. Then, after that, Erik Erikson developmental model helped us understand the longitudinal picture. So start from very early. Failures in trust, autonomy, initiative, and industry accumulate, and during adolescence, the stage of identity versus role confusion, the individual lacks the internal scaffolding required to consolidate identity. And the result is identity diffusion, a hallmark of borderline personality disorder. Then Marsha Linehan's biological model actually integrate temperament and environment. So patients have high emotional sensitivity and slow return to baseline, combined with an invalidating environment that dismisses or punishes emotional expressions. Over time, adaptive emotional regulation skills never develop. So, the key takeaway: borderline personality disorder is not a character flaw, it is a developmental disorder of emotion regulation, identity, and attachment. It is somewhat a cry for help, saying, that's what happened to me during childhood, and here I am. So, how to approach patients with borderline personality disorder? This is the $1 million question. The way clinicians, family members, and even friends respond to people with borderline personality disorder matters enormously. So, first, consistency is a treatment. Predictable boundaries reduces anxiety. Inconsistency escalates symptoms. Second, validate emotion without validating behavior. So you can say, I see how painful this feels, without endorsing self harm, aggression, or manipulation. Third, avoid power struggles. Escalation often reflects attachment threat, not defiance. We need to know that very well. Fourth, mentalize help the patient slow down and reflect. What were you feeling right before that happened? This restores reflective function, and don't be judgmental. Very important. Fifth, do not rescue and do not abandon. Extremes reinforce pathology. So the therapeutic stance is steady, boundaried presence. Clinically, patients with borderline personality disorder are exquisitely sensitive to rejection, inconsistency, and invalidation. Your emotional regulation often becomes the external regulator until they develop their own. So you're the one that is going to guide patients with borderline personality disorder to the safety. The good news is this: So borderline personality disorder is treatable, and prognosis is actually far better than most people think. Unfortunately, we don't have many resources in the communities. So actually, dialectical behavioral therapy, or DBT, is the most evidence-based treatment. It targets emotion regulation, distress tolerance, interpersonal effectiveness, and mindfulness. So DBT directly addresses suicidal behaviors and self-harm. Mentalization based therapy, or MBT, this one focuses on restoring the capacity to understand one's own and others' mental state, especially under attachment stress. Then we have the transference focused psychotherapy, or what we call TFP. This one uses the therapeutic relationship to integrate split representations of self and others. Schema therapy targets maladaptive schemas rooted in early developmental experiences. Medications has no curative role and can target symptom clusters, mood instability, impulsivity, anxiety, or transient psychotic symptoms, which could happen. Actually, that's the only personality disorder that could have many psychotic symptoms. Importantly, longitudinal studies showed that many patients no longer meet full diagnostic criteria over time, especially with structured treatment for borderline personality disorder with DBT or the other modalities. So really, the bottom line, this disorder it's not about being difficult. It's about a nervous system shaped by vulnerability and early relational failure. With accurate diagnosis, thoughtful approach, and evidence-based treatment, patients can do improve, and they do improve. If you feel that the patient is having borderline personality disorder, make sure you contact mental health provider that is very well trained in treatment and management of patients with borderline personality disorder, because it is extremely important that someone is well trained in that situation. So the bottom line, borderline personality disorder is not simply a difficult person. This is someone who had lots on their plates. So really, developmentally, they had very bad childhood and bad teenage years. Most patients with borderline personality disorder, they had some kind of abuse, mental, physical, sexual, or simply they had a rough childhood. So always remember, borderline personality disorder is a cry for help, and there's always help. If you found this helpful, please subscribe, hit the bell icon so you can get all the new content. Thank you very much for being with us. We'll see you next time.
If you found this video helpful, don't forget to like, subscribe, and hit the bell icon so you never miss future content.